Congenital heart defect is one of the most common birth defect identified under RBSK. Taking this into consideration, the topic selected for today's webinar is congenital heart disease, defects, its symptoms, diagnosis, and special needs of children with CHD. Please join me in welcoming our speaker for the day, Dr. Anita Saxena ma'am, who is an eminent pediatric cardiologist and Vice Chancellor at Pandit B.D. Sharma University of Health Sciences, Rohtak. Welcome, ma'am, and thank you for giving your valuable time for us. All participants are requested to put their queries in the chat box. We should answer them at the end of the session. Over to you, ma'am.
Thank you very much, Dr. Deepti, and thanks to Dr. Shobhana for keeping this topic, of course, for inviting me. So I will try and make it very simple, especially catering to the officers that you have at RBSK, and briefly touch upon the congenital heart disease problem as seen in our country. So let me begin by sharing my screen. Okay, I hope it's visible.
Yes, ma'am.
Okay, right. So the topic that we are going to talk about is CHD. Although Dr. Deepti did say that CHDs are becoming very important, they are one of the common birth defects, but I think over a period of time, over the last, I would say about 3 or 4 decades, with reduction in mortality due to infections, diarrheas, and nutritional problems, we are seeing more and more of these birth defects and of course some other conditions. And therefore, it is assuming more importance, as you would see that we are getting more and more patients, we are getting more aware of congenital heart disease, and we are having this particular seminar on congenital heart disease simply for that reason. Now, before I begin to talk about CHD, I just want to make a point here that yes, congenital heart disease is important for us simply because we are a country of almost 142 million or 1.42 billion people. We have a high birth rate. Total number of births is huge, and going by the prevalence of 8 per thousand, which is the world over prevalence, including a study done by us also, we expect that about 240,000 children are born every year in India with congenital heart disease. All of them are not serious. All of them do not need anything right at birth, but about a fourth or fifth of them are actually having very severe or serious heart disease, so to say, requiring treatment in the first few weeks or months of life. And if we extrapolate that data, it comes to about 48,000 of 240,000 are likely to have life-threatening conditions. Unfortunately, the total number of surgeries that was done in 2016-17 over a year period, which I published in 2018, was only 27,000. And obviously, this includes neonates and cardiac surgery under 1 year of age, which is very minuscule number, about 11 to 12,000 only. So one can imagine how much more capacity building is required for taking care of these children who are born with congenital heart disease. And of course, we have a huge pool of those who are in the system but have never been diagnosed or never have been treated. So you can imagine the burden is really, really humongous. Now, before I proceed, I just would like to let everybody a bit comfortable and familiar with the common terms that we'll be using when we are describing this congenital heart disease. Stenosis, I think all of you know, it means narrowing of a valve or narrowing of an artery. For example, pulmonary stenosis, aortic stenosis, mitral stenosis. Similarly, the valve can be regurgitant or incompetent, and that will be called regurgitation. Atresia would mean that there is absolutely no path, complete blockage. It could be a valve atresia, it could be a vessel atresia. Coarctation is commonly used for diagnosing obstruction in the aorta, but it can also be used for other blood vessels like pulmonary arteries. We often use the term hypoplasia, which means one of the ventricle or one of the vessel is smaller than what it should be. And we do talk about abnormally rotated great arteries, which we call as malposition of great arteries, a classical example being transposition. So I'm not going to be going much into the technique of congenital or technology and the terminology of congenital heart disease, but I'll take them as a whole group. And when we say group, we usually like to classify them as cyanotic and acyanotic, because that is what is obvious at the bedside when you're looking at a child. Of the acyanotic group, the common condition that we encounter are ASD, VSD, PDA, as we call them in short. Of the other group in the acyanotic is the obstructive lesions, and the common again diseases will be pulmonary stenosis, aortic stenosis, and coarctation, which are just producing an obstruction across a valve or a vessel. The cyanotic group is obviously more serious of the two. And here you can have the classical example of tetralogy of Fallot, which we all are familiar with, but there could be other conditions like tetralogy. And one can have this group of transposition or malposition where these children or these infants are really sick. And I would say of the entire group of CHD, this last group of increased blood flow with cyanosis is the one which requires urgent or very early attention in the neonatal period, and you're going to probably see them in the newborn nursery. Yes, more than one defect may be present in one patient. So one can classify in cyanotic, acyanotic. One can also, like, a lot of us want to classify them by severity because that will really have an effect on how to treat these patients, how early they require treatment. So if we talk of simple CHDs, which have a very good result in terms of treatment, in terms of follow-up, which is ASD, VSD. So these are acyanotic heart disease, as you can see, most of them, aortic stenosis, pulmonary stenosis. Then we can also classify as moderate congenital heart disease, where you have simple cyanotic heart disease. I would like to just take the example of tetralogy of Fallot. And then we have severe congenital heart disease. As I said, that these children may require something rather early, for example, transposition of great arteries and some other conditions. We also like to use the word complex CHDs because when you are counseling parents, then sometimes you like to know whether the child require multiple surgeries in future or not. And a lot of parents would want to know if my child is going to be fine after this particular surgery. So I think they have to be told right at the beginning that your child is having a complex congenital heart disease which may require multiple surgeries. Fortunately, this group is rather rare, but yes, we do encounter from time to time. Another term that we often use is called critical heart disease. Critical heart disease, which is actually a group of diseases which are dependent on patent ductus arteriosus. And once the ductus arteriosus closes in the newborn period, then these children really collapse. And I think pulse oximetry, which I'm going to talk about briefly, is something that is going to pick up these critical congenital heart disease by seeing that their oxygen saturations go down when they have one of these. And these are the patients who may be sent home by mistake because they look very fine. But on third day, fourth day, a week's time, they come back in a collapsed state because their ductus has closed. And therefore, these conditions are now manifesting with very severe condition. Again, although we talk of newborns with congenital heart disease most of the time, but one must remember that all CHDs do not present at birth. Many of them go unnoticed. They can present at any age, yes, at new birth and newborn also, especially critical CHDs, but they can also present at 5 months, 6 months, 1 year. Let's say large VSD may present at 6 months of age, and even in adulthood. But in general, the more severe disease is, the more complex disease is, it's likely to present earlier than later. But it is not uncommon to see adults also with congenital heart disease. Now, before I go further, let me just give you some tips as to how CHDs affect someone. Why are they important? How are they going to change the hemodynamics or the physiology of the heart? So physiological abnormalities can be classified into the following. The one is increased pulmonary blood flow, which means there is a left to right shunt, and therefore more blood is going from left ventricle into the right ventricle and into the pulmonary artery. So these children are not blue, but they have excessive pulmonary blood flow. The classical example could be ASD, could be VSD, or even PDA. The second group is that of a reduced pulmonary blood flow, where there is obstruction to the flow of blood into the lungs and often associated with a large VSD, and that is what we call it tetralogy of Fallot. Large VSD, severe pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy, thick muscle, because right ventricular pressure is equal to left ventricular pressure in such conditions. The third hemodynamics or third abnormality that may happen is called mixing of these return, systemic and venous return. So you have, for example, you have a very small right ventricle because of atresia of the tricuspid valve. So the blood from right atrium has to go to left atrium. It cannot come to the right ventricle, and therefore it gets totally mixed up in left atrium and left ventricle. And this is the blood which goes into the aorta and pulmonary artery. Obviously, these children are also blue because there's mixing of blood at atrial level, but the saturation in pulmonary artery, saturation in aorta, all are same because it is the same blood which is mixing here and going into the various parts of the body. And this is really one of the serious conditions in which you have unfavorable streaming. For example, if you have transposition where right ventricle is giving origin to aorta instead of pulmonary artery, left ventricle is giving origin to pulmonary artery instead of aorta. So obviously, all the body is getting blue blood and the lungs are getting red blood. Obviously, they don't need to have red blood because lungs are where the blood is purified. So this is practically incompatible with life unless there are mixing areas like AST, VST, PDA. So unless mixing happens, these children will not survive. Fortunately, they do very well during fetal life because we have an AST and we have a PDA in fetal life. But as soon as they are born, as soon as their ductus closes, they get into trouble. And lastly, which is much less common, is any regurgitation of the valve, which is classically seen in Epstein's anomaly. Again, it's a rare condition, may present at birth, may not present at birth. Now, what are the symptoms or clinical features of CHDs? First and foremost, we must remember that CHD or congenital heart disease group is a huge spectrum from very mild cases to very critical cases, as I showed you. So mild lesions may not produce any symptom unless there is a complication. And in such cases, the diagnosis may be made just by incidental discovery of a murmur, either at birth, but more often during school health examination or when they go for vaccination, the doctor may hear a murmur and may ask them to undergo more tests just to be sure that there is a heart disease or not. But those who have significant moderate to severe congenital heart disease are likely to present with symptoms, and these symptoms could be in the form of heart failure, that is breathlessness or exertion. It could be with cyanosis. It could be very serious, so they present with shock or collapse, as I said, in those newborns who have a ductus-dependent congenital heart disease. Rarely they may present with chest pain or syncope. So when we look at the common symptoms of congenital heart disease, where you should suspect that child may be having CHD, are breathlessness on exertion or dyspnea as we call it, failure of growth and development. So the mother will say that the child is not putting weight well, feeding difficulties, sometimes sweating while feeding, and then we call it suck, rest, suck cycle. So they suck for a while, then they're tired, they want to rest, and then they suck back. Cyanosis, if it is a cyanotic congenital heart disease, older children may complain of palpitations on exertion, and rarely they could be symptom of syncope. Syncope is rare, but never to be ignored, and therefore all children who are presenting with syncope must be investigated for any congenital heart disease. In fact, some of the patients have been referred to neurology because it was thought that they have an epilepsy disorder, and they turned out to be having something like complete heart block, which is congenital, or severe aortic stenosis, which can also induce syncope. On physical examination, yes, the commonest feature would be a murmur, may be associated with a thrill. There may be cardiomegaly on examination as well as on X-ray chest. If the child is blue, there would be cyanosis, there would be clubbing. Coarctation is very easy to diagnose provided you decide to palpate for the femoral pulses. If you don't palpate for the femoral pulses, you're likely to miss it because in children, we don't usually take blood pressure. Although coarctation, children have upper limb hypertension. And of course, you may have associations like Down syndrome or the other abnormalities or genetic syndromes, which may also should be made a note of, because when you are counseling these parents, it is important to tell them the entire picture. Conventionally, we have used NADA's criteria, which means systolic murmur, which is loud, more than grade 3, any diastolic murmur, even if it is soft, presence of cyanosis and presence of congestive heart failure. These are called major criteria. And in minor criteria, we have softer systolic murmur, abnormal second heart sound, abnormal ECG or X-ray, and abnormal blood pressure. And it is said that one major or two minor criteria would suggest heart disease. This is what the conventional clinical criteria have been, as something that has been there for many, many years. But you would realize that these criteria may not be fulfilled, especially in newborns, as I would go ahead and show you data. Conventionally, we used X-ray, ECG, oxygen saturation, something which has become a bedside investigation now. And of course, in certain cases, we do refer them for echocardiography to get the absolute correct diagnosis. And in certain cases, the doctor, the cardiologist may advise these children to undergo some more advanced tests like a treadmill or stress test, obviously for older children. Holter monitoring if somebody's suspecting arrhythmias. Sometimes we have them undergo CT angiography, MRI, and very rarely these days we do diagnostic angiography. We are usually doing angiography for treatment. Diagnosis is generally made by echocardiography, at best by computed tomography or CT angio. X-ray chest is very, very important. I would think that facilities are generally available, more freely available than for echocardiography. And if you're suspecting heart disease and you find there is cardiomegaly in an acyanotic child, it could be a VSD, it could be a PDA. In a cyanotic child, if you find black lungs, as is seen here, oligemic lung phase, and a boot-shaped heart, it gives you the diagnosis of tetralogy immediately. Obviously, you have to add X-ray to the clinical examination, and that is true for ECG also. But what I want you to remember is that a normal X-ray, normal ECG does not rule out congenital heart disease. Therefore, that must be remembered. Of course, we are all very fascinated by echocardiography, which is the end-all and be-all for congenital heart disease. You can make the diagnosis, you can rule out heart diagnosis, do whatever. But I just want you to know that it really depends on who's doing echocardiography. And therefore, we do have these training modules for echocardiography, because echocardiography is an operator-dependent investigation, and one must not do echocardiography in isolation. You must examine the child, you must take history, have the clinical data, only then go for echocardiography, even if you're trained in echocardiography, because clinical examination will tell you what to look for, what not to miss. Otherwise, echocardiography can really miss few things, it can make few things. So it is important to have the clinical data before going in for echocardiography. Now, talking to newborns, which is something that you're likely to see in SN News and all, yes, clinical assessment is very, very important, but what is now being picked up in many states of India itself, although it is mandatory in US, to do a pre-discharge pulse oximetry test for newborns. And I'm sure you're all familiar with what is a failed test, what is a pass test. Generally, we like to do it in the upper and lower limb both, and then see if there is a decrease in the saturation in lower limb compared to upper limb. And if there is an abnormality, then you repeat after a while. So pulse screening is becoming quite a routine. Of course, we have to do it very meticulously. We have to make sure that we are not, we are getting a good waveform and we are getting a good value. This is the study that I think all of you might have read, and some of you might have read. And I think there are many such studies where a large number of newborns have been screened using pulse oximetry. But what we showed in this particular study, which was published a long time ago, was that if you only do pulse oximetry, your sensitivity and specificity is not so good. If you only do clinical examination, obviously the specificity is extremely good, but sensitivity is quite low. But if you combine both of them, then you are likely to pick up a reasonably good sensitivity and specificity and very good negative predictive value of almost 99%. So this is for major CHDs. And if you look at critical CHDs, the combination of pulse oximetry and clinical examination becomes even better. 84% sensitivity with a negative predictive value of 99.9%. So pulse oximetry is good. Yes, of course, there are pitfalls to pulse oximetry, but pre-discharge pulse oximetry is likely to exclude at least critical congenital heart defects, may not exclude major congenital heart defects, and sensitivity of oximetry will increase. That of clinical examination decreases as the severity of CHD increases. Now, let's come to the management, because once you made a diagnosis, I think it is also important for us to tell the parents what sort of treatment are we thinking of. Are we going to go for surgery? Are we going to wait for a while? Or we are going to go for some other management? So it is important to understand, as I said earlier, CHD is a huge spectrum. And some of the congenital heart defects, like small ventricular septal defects, mild obstruction of the valve may not need any definitive treatment. In fact, you just need to call them for follow-up every couple of years. And unless there is a complication that happens, these children can very normally live their life to adulthood, undergo pregnancy, do whatever they want like normal human beings, and therefore they don't need to be intervened. On the other hand, if you have significant blockage like aortic obstruction or pulmonary obstruction or coarctation, some of these shunts like ASD and PDA, we can actually treat them in the cardiac catheterization lab without actually child undergoing any surgery. And I will show you some examples of such defects where you don't need to send them for surgery. However, other lesions like a large ventricular septal defect, like tetralogy of Fallot, these lesions do require surgical operation for their repair. And obviously, they cannot be treated without surgery or in the cardiac cath lab. Another important term that we talk about is palliation. So although majority of congenital heart defects can be repaired, you can use the word correction also if you like, but some of them may not be correctable. The classical example being single ventricle, where you cannot correct them into two ventricles. So this is what surgery you do for such children is called palliative surgery, because the underlying anatomy of the heart has not been changed. What has been done is to help the child to live longer, to live with no cyanosis, to have a as normal lifespan as possible, but the underlying heart condition is still uncorrected because it cannot be corrected. And such treatment modality is called palliative treatment. So in the surgical treatment, we have corrective surgery and we have palliative surgery. And let me show you some examples of these. This is a large ventricular septal defect. This is just a cartoon, a diagrammatic representation. A large ventricular septal defect, yes, surgically can be closed by using a patch. As you can see here, simple surgery, very good result, long-term outcome, excellent. On the other hand, you may have a condition like serious condition, critical heart disease called transposition. As I told you, aorta is coming from the right ventricle, pulmonary artery is coming from the left ventricle. So they're actually coming from the wrong ventricle. What you do is you cut them and you put them across and you correct it. This is called arterial switch operation because both arteries are being switched to their normal positions. This is also surgically done, but this is also total repair. So this is like a corrective surgery. On the other hand, you may have a patient who has either one ventricle or the other ventricle is so small, like over here, this is tricuspid atresia. There is no tricuspid valve. Right ventricle is very small. We call it hypoplastic right ventricle. And here, whatever you do, you cannot make a tricuspid valve. You cannot increase the size of right ventricle. So what you do is actually a palliative surgery where some kind of plumbing is done so that pulmonary arteries which are carrying blue blood are connected directly to the superior vena cava and inferior vena cava. So all the venous return of the body is going directly into the pulmonary artery without going through the ventricle. All the blood, which is red, is going into the aorta. So this is something which is called Fontaine operation, and there are various names for such kind of palliative surgery. But what I'm trying to show you is that here you have used one ventricle which was available to the systemic side, to the red blood side. And since there is only one ventricle, so the pulmonary side, which is blue blood, is going directly into pulmonary artery without going through the right ventricle, which it normally does. So this is palliative surgery. Nothing has been done inside the heart. It's only plumbing outside the heart, directing the blood from one place to another, and hoping that these children will live longer with less symptoms because they are no more cyanosed. Their aorta is getting all oxygenated blood or red blood. So this obviously will have repercussions after 15, 20 years, and such patients require very regular follow-up to look for any complication. When we come to cardiac catheterization treatment or non-surgical treatment, the classical examples are here. You have an ASD, you use an umbrella kind of a device which can be collapsed into this tube. You go from the femoral vein in the cardiac cath lab and deploy the device, closing this hole. Similarly, you can close a ductus arteriosus. So both ASD and PDA can be closed in the cath lab without resorting to open heart surgery. In fact, some of the VSDs can also be closed. I'm not showing you VSD because generally VSDs are large and they're better closed by surgery, because putting very large device in the heart is not a good idea. And of course, small VSDs do not need closure anyhow. This is obstructed valve. This is a pulmonary stenosis. Pulmonary valve is obstructed. Again, you take a balloon from the venous side, from the inferior vena cava, right atrium, right ventricle, across the pulmonary artery, inflate the balloon here, open the valve, and that will be a permanent treatment for this particular child who will be cured for almost ever. This is similar thing being done for aortic valve. Here, the catheter has gone from the femoral artery into the aorta, across the aortic valve into the left ventricle, and you inflate a balloon and you open the valve. Sometimes aortic valve may open with some complication or leaking, and these are the children who may need follow-up later in life also. This is coarctation being done by the balloon in a similar manner. So you can do some of the treatment of congenital heart disease in the cardiac cath lab without resorting to cardiac surgery. If it, the second question is when to operate. Yes, for small VSDs, we don't operate, as I told you, but for large VSDs, for PDAs, ASDs, you can do elective surgery or elective intervention in the cath lab, like for pulmonary stenosis or aortic stenosis. But one doesn't have to urgently send these children to a center for surgery. And why I'm bringing this out, because some of our cases that I have seen at AIIMS also are 10 days, 12 days old babies who have been diagnosed to have an ASD on echocardiography. They are doing perfectly fine, but they are being referred to a tertiary care center at such an early age that the parents are so worried. The children, traveling, these small babies traveling sometimes become hypothermic. So we have to be sure that this is the time that they should go for intervention rather than sending everybody right after making a diagnosis. Even tetralogy of Fallot patients, although we know requires surgery, but if the child is not having a cyanotic spell, if the child is mildly blue, there is no need to push him for surgery or for urgent surgery. Of course, there will be some exceptions. For example, if the child is very symptomatic, you may want to send such patients for early surgery. If the child is in heart failure, again early surgery. If there is severe pulmonary arterial hypertension, again earlier surgery. A tetralogy patient with severe blueness or severe cyanosis or even cyanotic spell, early surgery. Similarly, if there is ventricular dysfunction, you have severe pulmonary stenosis and there is right ventricular dysfunction, don't wait, send them for early surgery. So some subgroups will require early intervention, but those are usually very symptomatic patients, and you would know that they do need early intervention. However, you may require emergency interventions for critical valvular stenosis, especially when associated with ventricular dysfunction, severe coarctation of aorta, persistent cyanotic spell, tetralogy, transposition of great arteries, and some of other serious, more complex congenital heart diseases. Again, I want to highlight that all VSDs, all CSDs don't require surgery, don't require intervention. Small VSDs, mild aortic stenosis, mild pulmonary stenosis do not require any intervention, and they only need to be followed up maybe on a yearly or 2-yearly basis. So once we've decided that an intervention is required, the next question the parents are going to ask, what is going to happen to my child if my child undergoes an intervention? So the answer is that if the child had only patent ductus arteriosus, he is cured, and there is no need for even a follow-up for such children. If the child underwent ASD, VSD, coarctation surgery, or balloon dilatation for pulmonary stenosis, these are the children who are nearly cured. I would say do go for follow-up for the first 5-6 years. If nothing is happening, there is no need to come for follow-up. When we talk of tetralogies or transpositions, etc., again, the results are excellent. However, these are the patients who require long-term follow-up because there may be complications that may occur later. But generally, the follow-up is routine follow-up. There are no complications. They do very well. The problem is with single ventricle, for example, tricuspid atresia, where you have only one functioning ventricle. Here, the results of palliation are good, but over a period of 30 years, 40 years, 50 years, these children, when they become adults, they may become symptomatic because this particular ventricle, which is only one, may show features of fatigue and may start failing. So a regular follow-up is very important so that we treat whatever comes our way in the right time rather than waiting for the patients to develop symptoms. So whenever we are seeing such patients, we must counsel them that your child requires regular follow-up, preferably with a cardiologist at least every 2-3 years, but definitely with the physician or caregiver every year. And of course, these are the conditions where I said complex CSD, where you require multiple surgeries again, like you're putting a conduit for truncus, you're putting an artificial tube for pulmonary atresia, which is going to require a replacement. So I would say the results are still fair. But what I want to highlight is that 80 to 85% of our children with CSD would fall into first three categories, and therefore overall CHDs would have very good results if they're treated in time. And of course, they need follow-up for some of these subgroups. Now, coming to the special needs of children with CHD. As I said, some children with CHD will have absolutely no disability. They're fine. They're just picked up in school to have a murmur. But in some, there may be disability, and even if disability may increase. And the classical example is single ventricle, where over a period of time, there may be complications and there may be disability. Also, we have to treat the child as a whole. If the child has a Down syndrome or any other genetic abnormality, I think parents must be counseled about the issues that may come up because of Down syndrome and not necessarily because of congenital heart disease. Those who have severe CHDs would definitely need additional support, not just for hospital, for medicine, but also for schooling, employment, psychological well-being, and so on. And of course, when they grow up into adults, then pregnancy in women can put additional stress on heart of such patients, even if they have been treated, even if there has been an intervention or surgery in the past. And therefore, at the very beginning, when these children are being referred for an intervention of a surgery, it is important for the family to know what is in store for them, what is it that is required of the family to give support to this particular child for many, many years to come. Otherwise, the long-term outcomes are not going to be, very optimal. So regular follow-up is required even after surgery for many congenital heart disease, as I told you, for the following reasons, that many of them would develop one or the other complications. I'm not saying everyone, but even if it is 5% or 6%, we don't know which child is going to develop these complications. Therefore, they must be sent for follow-up on a regular basis. And this must be emphasized to the parents that even if your child is well, he or she must be brought for a follow-up either to the district hospital or to a cardiologist, depending on the problem, because they may develop arrhythmias, and this can be simply seen by an ECG. They may develop ventricular dysfunction, which could be clinical examination and an echocardiography. There could be residual problems, like classically after tetralogy of Fallot surgery, children do very well, but they are left with some pulmonary regurgitation, which requires 3-4 year every 2 or 3 years follow-up. There could be pulmonary hypertension, and there could be, of course, neurodevelopment. I would like to just dwell a little on the neurodevelopmental status, because a lot of studies are coming up now where it is shown that children born with CHD, even if they're operated, may not be as normal in terms of neurodevelopmental status as healthy children. I would just like to emphasize that majority of the children with CHD actually do very well. And we have done a study also on that. In fact, there are several studies which say that if you examine them cursorily, everything looks normal. If you do very, very detailed testing for neurodevelopmental status, using these various scales that we have, for example, Darcy scale and many other scales, you may pick up some abnormalities. But in general, they do very well. They cope up with life very well. They may have, an IQ which is not super normal, but I think they would on an average, they'll be able to deal with life, with schooling, with their studies, with their jobs and stress as well as normal children. So there may be neurodevelopmental status, but I think it is something that is more at a subclinical level, which is difficult to assess by the usual test. Yes, it will be picked up if you do very extensive scale evaluation on them. many of these visits can actually be managed at the DIC level or district level, and they need not come to the cardiologist. Yes, at certain points, you may want to refer them to the cardiologist if you find any abnormality. So what is the follow-up care? They require periodic clinical assessment, an ECG to look for any arrhythmias. They should be encouraged to maintain good orodental hygiene, maybe visit their dentist every year or so to ensure that there is no issues with their orodental hygiene. And this is important to prevent infective endocarditis. They must be asked to have regular physical activity. And this is something I would like to emphasize, because many a times the parents come and say, my child has had surgery, therefore I'm not allowing her or him to play in school or to go for gym. I think this is absolutely a misnomer. Majority of these patients would do very well after surgery. They would not have any problem, and they must be encouraged to have physical activity on a regular basis. Similarly, when a small child is there, we should ensure adequate nutrition. Many of these patients may be on medication, and therefore we should ensure on follow-up that they are taking those medications which have been advised. Those patients who are on blood thinners, for example, warfarin, and these are the children who would have had maybe a Fontan operation, or maybe these are the children who would have had a valve replacement with a prosthetic valve. They require close monitoring of their nationalized ratio or their measurement of blood thinning by periodic testing. And one specific word about antibiotic prophylaxis for infective endocarditis, and this is a question that is often asked, whether they need antibiotic prophylaxis before a dental procedure. The answer is that for majority of acyanotic congenital heart disease, operated or unoperated, they do not require any antibiotic before any dental procedure. Cyanotic congenital heart disease definitely need antibiotic prophylaxis. Those who have been operated with a prosthetic material in the heart, like a tube or like a valve, also require antibiotic prophylaxis for infective endocarditis. So for majority of patients with acyanotic CHD, like a VSD or an ASD or a PD or an ASPS, there is no need for antibiotic prophylaxis. What is needed is good orodental hygiene to be maintained, to be encouraged, to be emphasized at each follow-up visit. Some of these children will definitely require special tests like echocardiography, and you may have to refer them to a cardiologist or to a center where echocardiography can be done. So I'm going to conclude here by saying that it is impossible to remember every congenital heart defect, every repair, and the implications of it. I can understand that it's something that is very difficult. But what is important is to recognize the signs and symptoms which may indicate underlying CHD. Some defects can be repaired, but some can only be palliated, and those who can only be palliated would require lifelong follow-up. But I would like to add that some defects may not be repaired, may not require anything to be done, just follow up on a regular basis. And as we are getting, these services of CHD surgeries are getting better and better, we are going to have more patients who've been operated in the past for CHD into adulthood. And of course, those who are living with mild CHD also will be going into adulthood, living very well. It is important that we provide all the information to the family, we empower the family, we offer them as much help as we can, but it is up to the family really to take the child to the doctor, to take the child for the follow-up. But of course, at a district level, we can emphasize, we can reiterate, we can help them to come back to the hospital. But I believe that it is very important to treat these children as normal as possible, because if we treat them as special children, there are going to be a lot of psychological issues. So we must try and treat these children as normal as possible, but take care of their special needs, call them for a follow-up, investigate them if required. Thank you very much.
Thank you, ma'am. I I hope everybody had a very enlightening session. Couple of questions that have been asked by our colleagues who have joined us online. I like to pose them to you.
Sure.
Ma'am, regarding pulse oximetry, people have been asking about what are the diagnostic values that they should be taking into consideration when doing the pulse oximetry for detection of CASD in SNCU children.
So the
Can you
class,
just
I think conventional value has been 95%. Anything more than 95% is normal, anything less than 95% is abnormal. But we also must make, we all know that in the NICU, there are many other reasons for that desaturation. More often it is respiratory. In fact, in our own study, the majority of children who were desaturated were because of the respiratory issues and not cardiac. So 95% is the cutoff. But what we do is we do in the upper limb and we do in the lower limb and look for a 3% drop. What we had done in our study and what we've recommended is that just do lower limb. There is no need to do both, just do lower limb. If it is less than 95%, it is abnormal. Yes, you repeat after a while, you make sure there are no respiratory issues, but the cutoff is 95%.
मैम जस्ट एक रिक्वेस्ट आपसे और है, हमारे बहुत सारी एमएसटीज भी साथ में जुड़ी हुई हैं। कई चीजें जो आपने ऑलरेडी प्रेजेंटेशन में बता दी हैं, आई मैं दोबारा आपसे पूछूंगी, आप थोड़ा सा हिंदी में भी अगर एक्सप्लेन कर देते हैं तो उनके लिए बेटर होगा। मैम, हमने स्पॉन्टेनियस क्लोजर की बात करी है स्मॉल एएसडी एंड वीएसडीज में, तो कोई एज क्राइटेरिया होता है कि तब तक कब तक ये अपने आप क्लोज हो जाएंगे?
स्पॉन्टेनियस क्लोजर का सबसे लाइकलीहुड जो है वो सबसे ज्यादा पहले साल में, उससे कम दूसरे साल में, उससे कम तीसरे साल में, और 5 साल के बाद स्पॉन्टेनियस क्लोजर का लाइकलीहुड बहुत कम हो जाता है। जीरो नहीं, पर बहुत कम हो जाता है। लेकिन मैं ये ऐड करना चाहूंगी कि अगर स्पॉन्टेनियसली क्लोज नहीं भी हुई लेकिन वीएसडी छोटी है तो उसको बंद करने की कोई जरूरत नहीं है।
ओके, द अदर थिंग इज रिगार्डिंग the neurodevelopment part, ma'am, jo you have already talked about in the presentation. Can you just explain those things in Hindi also for our people at the DIC and the MHTs? न्यूरो डेवलपमेंट challenges इन बच्चों में होते हैं, नहीं होते? अगर होते हैं तो हमारे DIC का जो स्टाफ है, जिसमें हमारा पीडियाट्रिशियन, अर्ली इंटरवेंशनिस्ट, क्लिनिकल साइकोलॉजिस्ट सब होते हैं, उनको किन किन चीजों का ध्यान रखना पड़ेगा इनके असेसमेंट करते वक्त फॉलो अप के लिए?
तो मैं न्यूरो डेवलपमेंटल आउटकम के बारे में मैं यही बोलना चाहूंगी कि जनरली इतने ऑब्वियस न्यूरो डेवलपमेंटल आउटकम में इश्यूज नहीं होते हैं। ये बच्चे पढ़ भी लेते हैं, ये बच्चे नौकरी भी कर लेते हैं, मेरे कुछ बच्चे डॉक्टर भी बन गए, इंजीनियर भी बन गए हैं। लेकिन अगर आप इनको किसी स्केल से देखें, किसी एक पर्टिकुलर जो हमारे न्यूरो डेवलपमेंट के स्केल्स हैं, डॉक्टर्स और आई एम श्योर क्लिनिकल साइकोलॉजिस्ट भी उसके बारे में जानते होंगे, तो आप पाएंगे कि इनमें थोड़ी नॉर्मल से थोड़ी कमी है। ये बात बिल्कुल सही है कि नॉर्मल से थोड़ी कमी है, और ये खासकर उन बच्चों में होता है जिनको की साइनोटिक हार्ट डिजीज होती है, जिनका ऑक्सीजन लेवल ब्रेन का थोड़ा कम रहता है। और ये हो सकता है कुछ इस तरह के चेंजेस जो हैं वो एंटीनेटल पीरियड में, जब वो बच्चे पैदा भी नहीं हुए, फीटल लाइफ में भी हो सकते हैं। लेकिन मैं फिर से यही एम्फेसाइज करना चाहती हूँ कि वो इतने माइनर होते हैं कि उसके बारे में हमें बहुत ज्यादा बच्चे को बताने में एक साइकोलॉजिकल प्रॉब्लम आ सकती है। तो हमें उनको एक नॉर्मल बच्चे की तरह ट्रीट करना चाहिए। यदि उनको स्टडीज में वो पीछे पड़ रहे हैं या कोई स्ट्रेस में दिक्कत हो रही है तो उनको वो साइकोलॉजिकल सपोर्ट दी जा सकती है। लेकिन जनरली स्पीकिंग न्यूरो डेवलपमेंटल इश्यूज बहुत ज्यादा नहीं है। ये जो एक नॉर्मल स्पेक्ट्रम है उसके अंदर ही ज्यादातर बच्चे फिट होते हैं। हमें पता है नॉर्मल स्पेक्ट्रम में भी जो आईक्यू लेवल्स आप बात करते हो या एसक्यू लेवल, सोशल क्वेश्चन लेवल, वो 80% से 120, 130, 140 होता है। ये बच्चे भी उसी नॉर्मल में रहते हैं, 100 के आसपास या 80 के आसपास रहते हैं। तो इनको एक बहुत अलग पॉपुलेशन बना के हमें नहीं सोचना चाहिए। ये हमारे को दूसरे बच्चों के अंदर इनको जितना ये मिक्स कर सकें, जितना ये उन बच्चों के साथ रह सकें, वो इनके लिए लॉन्ग टर्म के लिए अच्छा रहता है।
Ma'am, another question that you have already answered in the presentation, but we need further emphasis on that, is the counseling of the parents. The example that you explained, that the parents don't allow the children to mingle with other kids or play the normal way. So when we are doing, whether our MHTs or the DIC staff people are speaking to the parents, what are the key messages that we need to give to the parents so that we don't have these issues?
तो पेरेंट्स को देखो, बीमारी के बच्चे को बीमारी है ये तो पेरेंट्स को पता होना बहुत जरूरी है, और उसकी डिटेल भी पता होना चाहिए कि उसको किस तरह की बीमारी है, उसका क्या फ्यूचर है और क्या उसको फॉलो अप की जरूरत है, क्या उसे हर साल फॉलो अप के लिए जाना है या कुछ ऐसे वार्निंग साइन है जिसको वॉच करना है। तो ये तो बहुत जरूरी है। लेकिन इसके साथ साथ ये भी जरूरी है कि उनका बच्चा एक नॉर्मल बच्चे की तरह ग्रो करे, नॉर्मल बच्चे की तरह पढ़े, नॉर्मल बच्चे की तरह खेले। तो हम जैसे मैंने कहा, हर सीएचडी को हम एक ही डिसीजन नहीं ले सकते हर सीएचडी के लिए। कुछ बड़े कॉम्प्लेक्स होते हैं, कुछ बड़े सिंपल होते हैं। यदि सिंपल सीएचडी है तो हम उनको यही बोलेंगे, जैसे स्मॉल वीएसडी का एग्जांपल ले सकते हैं कि आप हर साल आइए, 2 साल में एक बार आइए, 3 साल में एक बार इको कराइए, डेंटल हाइजीन जरूर रखिए जिससे इन्फेक्टिव एंडोकार्डाइटिस ना हो। लेकिन उसके अलावा आपके बच्चे को कोई रिस्ट्रिक्शन नहीं है, वो खेल भी सकता है, वो कुछ भी खा सकता है, वो स्कूल में भी पढ़ सकता है, सब कर सकता है। एक दूसरा जो एक्सट्रीम है वो ऐसा बच्चा है जिसको कि टेट्रोलॉजी ऑफ फैलोज था और उसका ऑपरेशन हो गया है। ऑपरेशन होने के बाद बच्चा एकदम दुरुस्त है, ठीक है, उसका नीलापन भी खत्म हो गया है, खेल भी सकता है। उसको भी हम यही कहेंगे कि आपके बच्चे को बीमारी है, फॉलो अप चाहिए उसको, आपको उसके लिए समय समय पर, हो सकता है एक ऑपरेशन की भी आगे जरूरत पड़े। लेकिन जब तक बच्चा ठीक फील कर रहा है, जब तक हमारे टेस्ट जो हो रहे हैं उनमें कोई खराबी नहीं आती है, तब तक आप बच्चे को नॉर्मल तरीके से रहने दीजिए, नॉर्मल खाने दीजिए। बहुत एक कॉमन क्वेश्चन पेरेंट्स का होता है कि मैं अपने बच्चे को खाने में क्या रिस्ट्रिक्ट करूं। आपको भी सुना होगा आपने। सबसे पहला आंसर उसका ये है कि कुछ भी रेस्ट्रिक्ट करने की जरूरत नहीं है। दिल की बीमारी में जो बच्चों में होती है, कोई रेस्ट्रिक्शन की जरूरत नहीं है। वो नमक भी खा सकते हैं, वो घी भी खा सकते हैं, वो मक्खन भी खा सकते हैं, आइसक्रीम भी खा सकते हैं। ऐसा कुछ भी रिस्ट्रिक्शन हार्ट के लिए नहीं है। हाँ, हम बच्चे को बहुत मोटा नहीं होने देना चाहते, ओबीज नहीं होने देना चाहते, जैसे कि नॉर्मल बच्चों को भी उस तरह की रिस्ट्रिक्शन हो सकती है। अदरवाइज खाने पीने की कोई रिस्ट्रिक्शन नहीं है। फिजिकल एक्टिविटी का हम ये बोलते हैं जितना बच्चा आपका कर सकता है उसको करने दीजिए, उसको रोकिए मत। बच्चे बहुत जनरली मैंने देखा है बहुत स्मार्ट होते हैं। जब वो एक पर्टिकुलर चीज नहीं कर सकते हैं तो वो अपनी लाइफस्टाइल उसी के हिसाब से कम कर लेते हैं। वो एक लिमिट तक जाते हैं, उसके बियॉन्ड नहीं जाते हैं। तो हमें उनको, इनफैक्ट मैं तो बोलती हूँ आजकल की, उनको फिजिकल एक्टिविटी में रेगुलर बेसिस पे होना चाहिए। बहुत सारे बच्चे हैं जो 15 साल 20 साल पे हो रहे हैं और वो इतने ओबीज हो गए हैं बिकॉज उनको उनके पेरेंट्स ने कहा नहीं नहीं तुम ये नहीं कर सकते, तुम वो नहीं कर सकते। तो हाँ, एक डॉक्टर की सलाह बहुत जरूरी है। मैं नहीं कहती कि हर बच्चा जिम जा सकता है या हर बच्चा कर सकता है, लेकिन आइसोटोनिक एक्सरसाइज जिसमें कि हमारी बॉडी के मूवमेंट होते हैं उसमें कोई रिस्ट्रिक्शन नहीं होती। आइसोमेट्रिक एक्सरसाइज जैसे वेट लिफ्टिंग, उसके लिए मैं हमेशा मना करती हूँ।
Ma'am, there's a lot of queries are coming regarding the pulse oximetry.
हम्म।
So the audience wants that if you can just explain the pulse oximetry part once again for all of them to understand it more clearly.
सो पल्स
What is the
ऑक्सीमेट्री की दो चीजें हैं। एक तो टेक्निकली पल्स ऑक्सीमेट्री अच्छी तरह से करना चाहिए, क्योंकि अगर आपने अच्छे से नहीं करा तो पल्स ऑक्सीमीटर कुछ गलत वैल्यू भी दे सकता है। तो उसके लिए जनरली आजकल पल्स ऑक्सीमीटर में एक तो वेव फॉर्म आती है, आप वेव फॉर्म से देख सकते हो। दूसरा, कई बार हार्ट रेट आता है। जब आप हार्ट रेट से संतुष्ट हो कि ये हार्ट रेट 120 दिखा रहा है या 130 दिखा रहा है, उस टाइम पे जो वैल्यू आ रही है उसे हम ले सकते हैं। लेकिन अगर हार्ट रेट वो 70 दिखा रहा है, 50 दिखा रहा है, तो वो वैल्यू ऑब्वियसली इरेटिक होती है। तो एक तो उसका टेक्निकल एस्पेक्ट है। तो इसलिए अच्छा पल्स ऑक्सीमीटर और उसको करने वाला दोनों ट्रेन होना चाहिए। उसके बाद हम उसकी वैल्यू को इंपॉर्टेंस दे सकते हैं। तो अगर हमने देखा कि हमारा ऑक्सीमीटर भी अच्छा है और हमारा करने वाला जो है वो भी ट्रेंड है, उस केस में जो वैल्यू 95% से अगर कम आती है, इसकी इसकी जो वैल्यू है वो 24 घंटे, बर्थ के 24 घंटे के बाद और ज्यादा अच्छी हो जाती है। विद इन 24 आवर्स पल्स ऑक्सीमेट्री की वैल्यू थोड़ी कम अच्छी होती है, मोर देन 24 आवर्स के बाद ज्यादा। लेकिन क्योंकि हमारे ज्यादातर बच्चे 24 घंटे में डिस्चार्ज के लिए रेडी होते हैं, हमें ये पहले भी करना पड़ सकता है। 95% से कम अगर आपका पल्स ऑक्सीमीटर में वैल्यू आता है तो उसको कुछ समय के बाद रिपीट करिए, बच्चे को वार्म कर दीजिए, देख लीजिए उसे कोई रेस्पिरेटरी डिस्ट्रेस तो नहीं है। अगर
ma'am?
पीडीए डिपेंडेंट है। और जब हम अपर लिम की बात करते हैं तो राइट अपर लिम हमें यूज करना चाहिए, लोअर लिम आप कोई भी यूज कर सकते हो।
Ma'am, can I just request to summarize these three, four important points in pulse oximetry in English also, because we have a wide population joining us, so we need to balance Hindi and English for both of them.
Yeah, sure. So I was saying that regarding pulse oximeter, it's an excellent test. There is no doubt about it. But there are two issues. One is the value, and the other is how are we doing it? So are we having the right kind of oximeter? Are we having the right person who is doing it? Because if you are doing it in someone where the pulse is not picked up well, that means the heart rate being shown on the monitor is 50, 60, 70. Obviously, you are not picking up every heartbeat. In such cases, whatever value is coming on the pulse oximeter is not right. So you have to see what is the heart rate. If the heart rate is coinciding with what the heart rate of the baby is likely to be, then the value being shown on the oximeter is correct. So that is one. So that's why I said it is also important to understand the person doing it is trained or not, because I have seen randomly people picking up saturation of 80%, 90%, and obviously blue children who are so blue, their oxygen saturation is being shown as 90%. So there could be fallacies, technical fallacies. Fortunately, all of us are very, very sensitive to this, and therefore we do know how to check pulse oximetry value. But just don't go by the value. See what is the heart rate like in the same machine that you have. Then the question is, what is abnormal? Anything less than 95% is to be considered as abnormal. You will see it in many babies because of apnea, because of respiratory problems, but you have to check it again. So there are two ways. One is you check it after a few hours and see whether it is normalized or not. And the second thing is to check the upper and the lower limb. If upper limb is more than 95, lower limb is 92, 93, there is a fall of 3%. And when I say upper limb, it is right upper limb. Then it is likely that this baby has a PDA dependent condition, which is a critical congenital heart disease and must not be ignored. And this may be a reason for this child to go in for an echocardiography to diagnose if there is a heart disease or not.
Thank you, ma'am. Ma'am, now we are just on the last leg of the webinar. Ma'am, can you please summarize the clinical sign and symptoms that need urgent referral, both in Hindi and English?
Okay. So urgent referral के लिए साइनोसिस, अगर किसी को डीप साइनोसिस या साइनोटिक स्पेल हुआ है, उसको अर्जेंटली रेफर करना चाहिए. किसी को बच्चे को डिस्ट्रेस या हार्ट फेलियर हो रहा है, उसका कारण कुछ भी हो सकता है, लार्ज वीएसडी हो सकता है या कोई और बीमारी भी हो सकता है, उसको भी अर्जेंट रेफरल चाहिए क्योंकि उन सब बच्चों को एकोकार्डियोग्राफी की जरूरत है. किसी को हिस्ट्री ऑफ सिनकपी है, बेहोशी की हिस्ट्री है, उसको भी अर्जेंट रेफरल होना चाहिए. और किसी को सीवियर चेस्ट पेन हो रहा है, उसको भी अर्जेंट रेफरल होना चाहिए. बट मेनली हार्ट फेलियर, severe cyanosis and syncope, these are the three conditions where urgent referral is necessary because these are indicative of very serious underlying heart disease. Of course there could be breathlessness, सांस फूलने में दिक्कत हो सकती है या सांस लेने में, खेलने कूदने में सांस में दिक्कत हो रही है, ये बच्चे का इन्वेस्टिगेशन आराम से हो सकता है. लेकिन अगर कोई ब्रेथलेस एट रेस्ट है, रात को सो नहीं पा रहा है, सीधा लेट नहीं पा रहा है, वो इसका मतलब वो बच्चा हार्ट फेलियर में है. सच चिल्ड्रन must be referred urgently for an assessment at a center where echocardiography can be done.
Ma'am, under RBSK, all the states have been working relentlessly to provide surgical care to the CHD children who are diagnosed. So, ma'am, key pointers that our DIC staff colleagues have to take into consideration for a long-term follow-up at the DIC, and what are the points they should look every time this child is coming to the DIC for follow-up? Ma'am, if you can just explain that both in Hindi and English for our audience.
So this we are talking of children who have been operated.
Yes, ma'am.
राइट. सो जिनकी सर्जरी हो गई है, उनके पहली तो क्लिनिकल असेसमेंट मैंने एक स्लाइड में भी दिखाया था. सबसे पहले क्लिनिकल असेसमेंट, उनको कोई सिम्टम है, और सिम्टम की जब हम बात करते हैं, ब्रेथलेसनेस ऑन एक्सर्शन सबसे पहला सिम्टम है, स्ट्रेस, सिनकपी, इस तरह का कोई भी सिम्टम है, पहले तो वो इवैल्यूएट करिए. फॉर्चुनेटली ज्यादातर बच्चे जो हैं वो एसिम्टोमेटिक होते हैं बिकॉज उनकी सर्जरी हो गई होती है, तो जनरली उनको कोई सिम्टम नहीं होता है. लेकिन अगर उनको सिम्टम है तो उसका इवैल्यूएशन चाहिए. उसके बाद आप एग्जामिन करेंगे, एग्जामिनेशन में कोई मर्मर है, स्टेथोस्कोप से देख सकते हैं, या साइनोसिस है जो कि आप पल्स ऑक्सीमीटर से भी देख सकते हैं, या कोई एविडेंस ऑफ हार्ट फेलियर, दैट मींस लिवर बढ़ा हुआ है या नहीं. उनका हार्ट फेलियर का बच्चों में सबसे इंपॉर्टेंट फिजिकल फीचर होता है हेपेटोमेगली और enlargement of the liver along with breathlessness. So टेकिपनिया, टेकिकार्डिया एंड हेपेटोमेगली, ये तीन जो ट्रायड है, ये हार्ट फेलियर इंडिकेट करता है. तो अगर कोई फीचर हार्ट फेलियर का है, अगर उसको क्लिनिकली कोई मर्मर नहीं है, हार्ट फेलियर नहीं है, ब्लूनेस नहीं है, पेशेंट एसिम्प्टोमेटिक है, तो बहुत अच्छा रिजल्ट है. उसको आप फॉलोअप के लिए 1 साल के बाद, 6 महीने के बाद बुला सकते हैं. यदि उसको इसमें से ऐसा कुछ भी है तो आपको उसको फर्दर इन्वेस्टिगेशन करना पड़ेगा. और मैं कहूंगी एक्सरे और ईसीजी पहले होना चाहिए, सीधा एकोकार्डियोग्राफी के लिए ना भेजें, क्योंकि छोटे छोटे मरमर, या मान लीजिए किसी का वीएसडी के लिए ऑपरेट हुआ है और उसको छोटी सी मरमर आ रही है, वो हो सकता है एक छोटा सा रेजिडुअल वीएसडी हो जो रह गया हो. उसके लिए कोई भी टेंशन लेने की बात नहीं है, पेशेंट को एसिम्टोमेटिक होगा, एक्सरे में कुछ नहीं आएगा, ईसीजी में कुछ नहीं आएगा। यदि ये सब नॉर्मल है तो आप उसको आराम से फॉलोअप के लिए बाद में बुला सकते हैं या कभी लेटर ऑन उसका इकोकार्डियोग्राफी करा सकते हैं। लेकिन अगर किसी को हार्ट फेलियर है या किसी के हार्ट एनलार्ज है, एक्सरे में आप देख रहे हो कार्डियोमेगली है, या ईसीजी में कोई मेजर एब्नॉर्मेलिटी आ रही है, ऐसे बच्चों को हमें तुरंत ऐसी जहां से उनकी सर्जरी हुई है या तो वहां या किसी पीडियाट्रिक कार्डियोलॉजी के सेंटर में भेजा जा सकता है। Majority of these issues can be sorted out by good clinical examination, good history, one X-ray chest and one ECG. Majority of decisions can be made based on that because diagnosis आपको already पता है. You know that this child had this heart disease, has been operated for this heart disease. It is not you're trying to diagnose. Diagnosis is already there. You're only trying to find out if there is a complication, if there's a residual problem or not.
Ma'am, the last thing that we'll request from you is to re-emphasize the fact that not all children need surgical management, so that unnecessary referral and inconvenience to the patients can be avoided. आप एक बार हिंदी और इंग्लिश में दोनों हमारे MSTs और DIC colleagues के लिए बता देंगे तो it'll be very good for them.
श्योर श्योर। सो जो माइल्ड डिजीज जिसको हम बोलते हैं, जैसे कि स्मॉल वीएसटी, सबसे कॉमन एग्जांपल मैं लूंगी स्मॉल वीएसटी का, या एक छोटा होल इन द हार्ट जिसको हम बोलते हैं। स्मॉल वीएसटी का ऑपरेशन कभी भी उसकी जरूरत नहीं पड़ती अनलेस कोई कॉम्प्लिकेशन हो जाए, जैसे कि इन्फेक्शन हो जाए वहां पर या कुछ वाल्व की खराबी आ जाए। बट कन्वेंशनली स्मॉल वीएसटीज डू नॉट रिक्वायर क्लोजर। देयर इज नो नीड टू रेफर अगेन एंड अगेन। यस, यू मे वांट टू कंफर्म योर डायग्नोसिस वंस, उसके लिए आप एक एको करा सकते हो, लेकिन उसके बाद उसको बार बार भेजने की जरूरत नहीं है। 3-4 साल में एक एको होने से भी काफी रहेगा। दूसरा जो एग्जाम्पल है ऐसे माइल्ड डिजीज का, वो है माइल्ड एओर्टिक स्टेनोसिस, माइल्ड पल्मोनरी स्टेनोसिस, जिसमें वाल्व की थोड़ी ब्लॉक होती है। अगेन सच पेशेंट्स डू नॉट नीड एनीथिंग, दे जनरली डोंट प्रोग्रेस, बट येस दे डू रिक्वायर echocardiography from time to time every 2 to 3 years to be sure that जितना उनका ऑब्स्ट्रक्शन है उसका लेवल बढ़ा नहीं है, उतना ही है। सो इस तरह की जो दिक्कतें हैं, इस तरह की जो चीजें हैं, वो आप क्लिनिकली डायग्नोस कर सकते हो, और अगर आपके पास एक्सरे ईसीजी की सुविधा है तो एक्सरे ईसीजी कर सकते हो, वो भी नॉर्मल होगा इनमें। सो इफ एक्सरे ईसीजी इज नॉर्मल, क्लिनिकली इट लुक्स लाइक ए माइल्ड डिफेक्ट, पेशेंट इज एसिम्प्टोमेटिक, देयर इज नो नीड फॉर रेफरल। Yes, there could be a referral every 2-3 years for an echocardiography for looking for any complication. पर हमारा उनको एडवाइस होता है कि उनका डेंटल हाइजीन अच्छा रहे, ब्रश वगैरह करें, डेंटिस्ट को देखें, जिससे कि कोई कॉम्प्लिकेशन जो इन्फेक्शन का होता है वो ना हो जाए। स्मॉल वीएसडी का एक यही कॉम्प्लिकेशन है जिससे हम लोग घबराते हैं, वो है इन्फेक्शन। So they must maintain good oral dental hygiene. It is our duty when they come for follow-up to tell them to make in terms of heart.
Thank you so much, ma'am. Thank you. And I hope on behalf of the National RBSK team and all the participants, we thank you for such an enlightening session we had and answering all our questions again and again. Thank you so much, ma'am.
Thank you. Thank you. Thanks.
Shall we end the meeting?
Yes, please.
Okay. Sachin, please end the meeting.
Sure, Meena. Thank you so much. Thank you so
Okay.
much, Dikti.